Viral conjunctivitis. It is caused by herpes simplex type 2 virus. It is rare cause of neonatal conjunctivitis. It is transmitted from mother during delivery. Onset is subacute between 1 to 2 weeks after birth. It is characterized by blepharoconjunctivitis. Corneal involvement keratitis may occur. Chemical conjunctivitis. Its presentation is within few hours after the use of prophylactic silver nitrate or antibiotic drops. There is mild conjunctival hyperemia which lasts no longer than 24 hours. Treatment is not required. Treatment. Chlamydial conjunctivitis, inclusion conjunctivitis, topical antibiotics, tetracycline 1%, eye ointment or sulfacetamide 10%, eye drops for 4 weeks. Systemic antibiotics, erythromycin 50 mg per kg in divided doses for 2 weeks. Gonococcal conjunctivitis, topical antibiotics such as benzyl penicillin, gentamicin or tobra drops. Systemic antibiotics, benzyl penicillin 50,000 units per kg in 2 divided doses for 7 days. Cefotaxime 100 mg per kg, single intramuscular injection is effective. Other pathogens, bacteria. Topical antibiotics such as neomycin, tobramycin drops during daytime and ointment at bedtime. Systemic antibiotics such as cefotaxime may be considered in severe cases. Viral conjunctivitis, topical acyclovir 5 times per day. Topical antibiotics prophylactically to prevent secondary infection. Systemic acyclovir for 14 days. Complication: keratitis, corneal ulceration, corneal opacity, conjunctival scarring. Allergic conjunctivitis. It is the inflammation of conjunctiva characterized by itching and redness of eye due to hypersensitivity reactions to allergens or antigens. Conjunctiva is more sensitive than skin to allergens. Types: acute allergic conjunctivitis, seasonal and perennial allergic conjunctivitis, vernal keratoconjunctivitis, atopic keratoconjunctivitis, follicular keratoconjunctivitis. Acute allergic conjunctivitis. It is acute allergic inflammatory reaction of the conjunctiva to an environmental allergens. Clinical features: it is type 1 hypersensitivity reaction. The environmental allergen is usually pollen. It is typically seen in younger children playing outside in spring or summer. Acute itching and watering are the common symptoms. Chemosis of conjunctiva is a hallmark. Treatment: cold compresses, topical antihistamine, topical 0.1% single drop of adrenaline is effective to reduce chemosis. Mast cell stabilizers are very effective. Vernal keratoconjunctivitis or spring catarrh or vernal catarrh. It is a recurrent bilateral allergic inflammation of conjunctiva. Etiology: it is hypersensitivity reaction to exogenous allergens which act as antigen. It involves type 1, type 4 hypersensitivity reactions. Age: common between 5 to 15 years. Sex: more common in boys than girls. Season: more common during spring and summer season. Family history: 2/3 of the patients have a close family history of atopy. Atopy is a genetically determined predisposition. To hypersensitivity reactions upon exposure to the specific environment antigens. Pathogenesis exogenous allergen act as an antigen and reduce the formation of IgE antibodies. Antigen-antibody reaction occurs on the surface of mast cell, causing degranulation of mast cells with the release of chemical mediator histamine, serotonin, slow-releasing substance. The chemical mediator produce inflammatory symptom sign in the conjunctiva and cornea. Clinical types. It occurs in three forms. Palpebral form primarily involve the upper dorsal conjunctiva. Limbal form primarily involve the limbal region. Mixed form the feature of both palpebral and limbal disease. Symptoms. They are more or less same in three forms and include bilateral involvement with recurrent itching is the main presenting symptom. The other symptoms are lacrimation, photophobia, burning, foreign body sensation, and increased blinking sign.